Welcome back to Reconfiguring Reality. I'm Chesh.
I'm the Jericho.
I'm Laura.
And I'm Jessie.
Today, our guest host is,
I'm Krista.
and today's topic is going to be on dissociative identity disorder and borderline personality disorder. We're going to start with what? Dissociative identity disorder, or DID.
Yeah, which used to be multiple personality disorder.
Yes.
So I found
Not to be confused or associated with schizophrenia, which is a completely different thing, and they get lumped together a lot, and it's not right.
I
Isn't that
didn't
kind
know
of like
that.
Sorry.
comparing ADD and ADHD?
I'm
Yeah.
sorry, what?
There's a lot of illnesses, mental and physical, that often have like a lesser or greater version that get compared to one another, but there's distinct differences that separate them. And so I said it's something similar to like when people think ADD and ADHD are the same disease, and therefore they have the same symptoms. They do share some things that are closely related, but others are different.
Okay. All right. I have here from it's the Merck Manual consumer version, and it says that in dissociative identity disorder, formerly known as multiple personality disorder, two or more identities alternate being in control within the same person.
Did you know some people have up to 100 alters and with DID?
100?
Yeah.
Wait, I thought they could
Damn.
only have I don't know. I didn't think
Well,
there was
from
an
the
actual limit.
Cleveland Clinic, the core identity is usually personality. Alters are alternate personalities. Some people with DID have up to 100 alters.
Jeez.
So it's okay. Is this a dumb question? Because I don't know much about this. It's like Nurse Jackie, isn't it? Or is that something totally different?
I need you to explain Nurse
I don't know
Jackie
what
because
Is
I
it
Nurse
haven't
Nurse?
Jackie is.
I haven't
Think
seen it.
I think Nurse Jackie was addiction.
Which
It's
one am I
the
thinking of
United
then?
States of Terra.
Thank you. That's what I'm thinking of. That's the one.
I was gonna say,
And I was going to recommend
Isn't Nurse Jackie the one that was screwing the pharmacist for drugs?
yeah,
Like the series ended.
No,
but
I was
she
thinking
OD'd.
United States of
the
Terra.
United States of Terra, and I was actually going to recommend that. I was talking to Laura about it earlier this week. It's actually a very good representation of DID and of someone who has multiple alters and what it's like not only to be the person who has DID, but to be the family members and caregivers and supports of that person. They did a really, really good job with that show.
And Krista, how do you know that?
How do
Ooh.
I know that?
Yes.
Well, I dated and lived with someone who was diagnosed with DID. And so I lived that life for like 3 years. And it was definitely always interesting.
So was it like being in a poly relationship?
No, because just like on the show, we had rules. And my ex-partner had 3 separate alters in addition to her. So there were 4 people total.
So let's call them A,
Her
B, and C.
So A was a 3-year-old preschool aged girl. B was a 15-year-old boy crazy girl. And C was a grumpy, jaded, cynical 30 something year old lesbian. My partner who hosted all of these altars, was a very mask lesbian in her, I think at the time we were together, she was in her late 20s.
I thought it was her early 20s, or maybe mid.
Well, it was 10 years ago. So she would have been in her late 20s, early 30s.
Oh.
Because I'm 6 years older than she is.
Oh, okay. I didn't realize that.
Yeah. It's been a minute.
So I'm guessing for like people who don't, because I mean, I'm having a bit of trouble following the conversation until Krista said that, but it's pretty much like they have triggers and whatever trigger causes whatever personality is whoever you get kind of thing. If I'm understanding this correctly.
Sometimes it was that. Sometimes. So for her big trigger that would make her transition would be stress,
Mm-hmm.
which makes sense because, you're stressed out, your brain wants to protect you. So you transition to an alter that will protect you in that situation.
Another one of her triggers, though, was her seizure disorder, right?
She has a seizure disorder, and when she would have a seizure, when she came out of the seizure, she wouldn't come out as her host self. She would come out as the 3-year-old.
So the host being the original
The original
personality.
person.
Yeah.
Patient 0.
Yeah, patient 0. But so she would transition during the seizure, and when she would come out of the seizure and she would be conscious again, she would be her 3-year-old alter. That got really difficult for me because she had lost her dad when she was 13, and the patient 0 and the older 2 alters had kept that information from the 3-year-old. And don't
Mm-hmm.
ask me how that works because I have no idea, but I find it fascinating. But she would come out of that seizure looking for her dad, wanting her dad's comfort because she's 3 and scared because she just had a seizure. And I would have to do damage control
and skirt around
and
the issue that dad was
redirect
passed away.
well, I can't get him right now for you, honey, but I'm here and I can keep you safe and I'll help you. So it was very interesting, and I do think that her 3-year-old alter felt safe with me, even though there's a good chance she had no idea who I actually was, because I have that mom vibe and I've been told by so many people I have a mom vibe. So it was like she knew I was a safe space, and so she would calm down. But like I said, I have no idea how they kept that information hidden from her because it's all kind of the same brain.
I think if I'm again, I don't know anything about this. I'm coming in probably as blind as our audience. But from my understanding with the brain in that aspect, certain portions of it kind of shut down information wise. So to me, it makes sense that if she's her 3-year-old self or alter, if that's the correct term, certain portions of her brain are not like connecting the information that's already, that she already knows.
Well, and it kind of makes sense too because, like, patient 0 doesn't remember some of the stuff that A, B, and C do, right? She has
Mm-hmm.
Right.
lapses of memory. So
Right. When
obviously, if she has lapses, then obviously they can make lapses in the other personalities.
when she would transition, the time that she spent as her alter, she would not have full recollection of. She might have bits and pieces, it might come back in a flashback, but she didn't have any real memory of what was going on. We were at a sci-fi convention right when we first started dating, and it got really overwhelming for her because of all the people and the crowds. And if you've ever been to a sci-fi convention, like they're a ton of fun, but they're very like you get very like overstimulated. There's a lot of sensory input, and
Mm-hmm.
she transitioned just to have a little bit of downtime. Didn't like, and she never transitioned intentionally. That was never anything that was a thing. And she transitioned into alter B, which is a 15-year-old who's very boy crazy, confused the crap out of my friends that we were there with because all weekend she had presented very gay. And now she's checking out all these male celebrities and these boys that are walking around. And I'm just going, you need to stop. You need to be quiet, lower your voice, calm down. I know those boys are cute, but let's just like bring it in. Um,
Yeah,
and
I
when she
can't picture
transitioned,
I can't picture her like that at all.
back out to like the altar kind of went back to sleep or whatever, she was so confused because everyone was looking at her weird and she's like, "What? What did I do?" And I was just like, "We'll talk later. We'll handle it. It's fine."
So
Yeah, that definitely sounds like portions of the brain when she switches to an alter stop
Mhm.
communicating.
so I knew patient 0, and I am positive that I met personality C. I think I may have
Oh.
met personality A once, but I never met B.
So I only saw B once or twice. Um, A, I saw more often because of the seizures.
Mm. And that's when
There
I
was
would
one
have met her
time,
too, because I was witness to
yeah.
one of the seizures.
There were a couple of times that she transitioned to a just like throughout the day, like it was a really hot day and she was really like overheated and stressed out and she transitioned and my kids were around and my kids were preschool and early elementary age at the time and they just thought that patient 0 was just being silly and laying on the floor coloring with them. Like they took it all in stride, like whatever, it's fine. um but as far as I know, they never met the other two alters. Or if they did, they were in their own little kid world and it didn't
Do you
phase them
know
at all.
when I met patient B or C? It
No,
was in your kitchen. Remember when I had that really bad like ingrown hair or something under my arm,
mhm.
and patient 0 was taking care of it for me. Patient C presented herself
Oh,
while we were doing that.
hmm,
Because I
interesting.
remember patient zero's demeanor, her entire demeanor changed, and she just started being like this mega bitch, and I was just like, step off. Like, what the fuck?
Even the look on her face changes,
Yeah,
like,
yep.
Now,
everything.
I was gonna ask, could you tell when they were I guess I like they when with BPD, it's called splitting.
Mhm.
So that's kind of like how my brain when they split and switch, like could you tell when it was happening or was it instant?
It was instant. Like, one
Okay.
minute it would be patient 0, the next minute it would be one of the alters.
Cuz
But you
So
And
kind
I
of
couldn't.
like
mean
no
I
warning.
followed, yeah, I follow some people who have DID, and sometimes you can tell when, like they'll record when they're changing,
no,
because one, they don't recognize when they're doing it, and their like partners can kind of tell when it's happening, so they'll start recording,
Uh huh.
and then
mhm.
that way they can see and be like, oh wow, I didn't know I did that.
I do wish that at some point in our relationship, I had recorded her before and after transition, just so that she could see how her entire, like Laura said, demeanor, like the look on her face, the way she carried herself, like everything, even like her speech patterns, everything changes. And obviously when you're transitioning from a 20 something year old to a 3-year old, your body language is going to change because 3-year
Hmm.
olds are little kids. um but just so that she could have been able to bear witness to the changes in her and just the way that her alters behaved, just to give her some insight into it.
Well, I also think recording it because, like we've discussed before, they don't really remember or know what happens when they come out. So I think it really fills in the blanks for them of like, okay, well, I was just like blacked out for a good, I don't know, 30 minutes. What happened?
Right, right.
Well, to the thing about having multiple versions in one person is it's not uniform, right? So like some people have clear memories of one persona and have no memories of another because of um, comparting their thoughts. So it's not just different areas of the brain; it's just different sections of storage is being used, kind of like booting up one program over another, and they're not always aware of the change or behavior or the impacts. And the triggers are also different. Some people do it defensively or offensively when certain situations rise. Other people have no control over it. Some people can willingly control it. They reach sort of like a hive mind where they can talk to one another and bring forth a personality similar to how you would be at a table full of people and say, okay, you go up and talk to the reporter next. So it's actually a very interesting field.
Yeah, the brain is amazing to me and the way that the brain works because the thing with DID is unlike a lot of other mental illnesses, DID is not one that you're necessarily born with or is genetic. It's the brain's way of kind of shattering into pieces to protect the person from some trauma that has happened.
Before we get
And
into the causes of, I'm sorry, before we get into the causes of DID, I want to hit real quick the two different forms. Did you know that there are two forms of DID?
I didn't know that.
Mm-mm.
So there's possessive and non-possession. I'm sorry, possession and non-possession. In the possession form, the person's different identities appear to be outside agents who have taken control of the person. This outside agent may be described as a supernatural being or a spirit, often a demon or god, who may demand punishment for past actions, but sometimes it's another person, often someone who has died, sometimes in a dramatic fashion. In all cases, people speak and act very differently from the way they normally do. Thus, the different identities are obvious to other people. In many cultures, similar possession states are a normal part of local culture or religion and are not considered a disorder. In contrast, in DID, the alternate identity is unwanted, causes substantial distress and impairment, and appears in times and places that are inappropriate for the person's social situation, culture, and or religion. Non-possession forms tend to be less apparent to others, although they may display a sudden shift in affect or interpersonal manner. People may feel a sudden alteration in their sense of self, perhaps feeling as though they were observers of their own speech, emotions, and actions rather than the agent. So I'm guessing patient zero was non-possession.
Yes, that's what it sounds like to me.
Yeah, it sounds more like a classification than a totally separate. Because I know people have both at times as well. There's some people who have possessive personalities that can take control, and then other ones who are passive and have to be either coaxed out or only come out in rare situations.
And the idea of the outside influence, that's interesting to me because patient 0 also had schizoaffective disorder and had visual and auditory hallucinations that went with it. So I could see how she would have also felt like there was an outside entity trying to control her as well.
Is that one the one that you just said? Schizo what?
Schizoaffective disorder.
Is that hereditary?
I believe it is. I can look it up and see.
Because we were talking about the causes of DID, and you said that they weren't hereditary.
Not to my knowledge. This is more of a protective factor kind of thing that the brain does when there's been significant trauma. And for patient 0, she did experience a number of significant traumas and also struggled with addiction. And so her alters were there, because the trigger is stress for her and confrontation. Whenever things would get to be too much and overwhelming, one of the alters would step in to kind of protect her and give her that space.
Patient zero was a smoker, but personality C hated cigarettes, right?
Yes.
I find that interesting. So I have it
Well,
here.
and also, patient 0 smoked marijuana, but none of them would let patient A anywhere near it, and they tried really hard to keep patient B, who's 15, away from it too.
Yeah,
Yeah, well, that didn't work so well, but
right. I have it here that says DID usually occurs in people who experienced overwhelming stress or trauma during childhood. I
yes.
also have a statistic here that says that DID is very rare and the number of people who have it is unknown because of how hard it is to
Mhm.
diagnose.
Not
What?
only is it difficult to diagnose, but a lot of people don't believe that it's actually a thing. A lot of people get accused of faking it and just to, like, get out of trouble
Did
or
you ever feel
whatever.
like patient zero was faking it?
No, never. Never once.
Jess, I
I
think
think
you wanted to
because
say something else.
Uh, and I think it's more like because I think it was like it affects less than 1% of the population, but it affects women more in that 1% than men.
Oh, I didn't know that.
and if you
yeah.
consider that it's a defense against traumatic experiences, especially in childhood, that makes sense because unfortunately, it seems to be that females experience more significant trauma in childhood. If you look at the statistics for different traumatic events that happen in childhood.
I want to read this next section, and Krista, I want you to think of patient zero when I read it because you know the
Okay.
trauma of her past.
Like what her traumas were. Yeah.
Yeah, it says in the United States, Canada, and Europe, about 90% of people with this disorder have a history of severe abuse, whether it be physical, sexual, or emotional, or neglect during childhood. Some people have not been abused but have experienced an important early loss, such as the death of a parent or serious medical illness or other overwhelmingly stressful events.
Yep. Yep.
J-
Absolutely.
yeah, check off all the above, right?
Mhm. Not
So
the abuse piece, not the abuse piece. I will say that when it came down to it, even though her parents had their own problems, there was never abuse or neglect to my knowledge, but there was definitely the loss of a parent and a lot of other just not great situations for a kid to be growing up in.
Jericho?
to comment earlier, so the field of mental health is still a very controversial field. The old mentality of like, why didn't people in yesteryear have these mental issues and then now we have them? It's because they were explained in other ways. Like we're realizing that mental health has always been an issue. It's never been something new or that is purely like systemic based on culture or developing societies. In reality, it's just eccentric people back in the day were people suffering from mental illness. They just didn't necessarily know what to call it back then, right? So you had Uncle Jake, and Uncle Jake talked to his favorite squash that day. That's just Uncle Jake. So
Yeah, but you can also see that, I mean, as a point of confirmation, PTSD in the military wasn't a thing until how long ago? Like, although soldiers have had it for decades.
well, a new
Well,
term,
and
yeah. They used to call it shell shock back in the day, but yeah, they were
right.
aware that soldiers would suffer demons from battle. That's not nothing new. It just got a fancier term. But
Well,
along those
And now
lines,
they
like
understand it better.
with children and the difference, this is another issue is like so women, right? Like women and men when they're young, when they're children, generally experience about the same amount of trauma. However, women are twice as likely to suffer PTSD from that trauma because of cultural biases and because the difference between how men and how women process emotions. Men are sort of gifted with a borderline level of bluntness, but the culture, especially in the West, is suck it up, walk it off, that kind of thing. The expectations are that you bury those emotions, and so they often, although suffer trauma, don't really show the signs and effects of it in outward or direct ways that are outside what people consider normal behavior for quote unquote men. So, a lot of times when a woman is emotional, it's accepted and just understood to be as women are in touch with their emotions, whereas men, they always seem to be, you know, stuck in this stereotype of being unaffected by emotion. In reality, it's just they're contained and not explored. So many men nowadays are realizing that they too suffer from trauma and things like DID, and it just, they don't express those or don't come for that aid, or they don't want to make those kind of things known. They try to bury that stuff. You see it a lot more in veterans and homeless, uh, where they don't have societal ways of hiding it because they're stripped from things like video games and drinking and things that they can easily obtain.
I have lots of thoughts and some information. So, to answer the question about schizoaffective disorder, it says Among individuals with schizophrenia, there may be an increased risk for schizoaffective disorder in first-degree relatives. The risk may be increased among individuals who have a first-degree relative with schizophrenia, bipolar disorder, or schizoaffective disorder. So there is a genetic component to schizoaffective disorder.
Okay.
And like to kind of piggyback on Jericho's thought of, like it's not that more people have it, it's that we're more aware. Thinking about the different designations of DID, is it any wonder there was such an uptick in exorcisms back before we really understood what DID was?
Right.
Because what does it sound like?
Possession.
And and it's funny because there's an episode of Criminal Minds where Prentice and Rossi are having a conversation, and he takes her to the house where the first exorcism took place, the one that the movie The Exorcism is based off of. And he says, there was a lot of craziness that went on, and they burned, like the fire department burned the house down, all because some guy probably had schizophrenia and had delusions and hallucinations, or had DID.
Mm.
But everyone was so convinced that it was a demonic possession. So that just is interesting to me, that as we get more educated, how things shift and change.
So
I think a good label for it would be a spectrum, right? Like we talk about people nowadays transitioning to in lifestyle. I think mental health is beginning to realize, like with autism, that there's not just one type, right? And there's not just one severity, like you're either on or off. Like it's now everyone has tendencies, and we're beginning to realize that the brain functions largely the same across all of us. It's just some situations in life cause some people to trigger things that, trauma, that call for a stronger response to how the brain would normally, right? Some of us just, we get mad and we bitch about our day, right? That's how we deal. That's how we de-stress. Other people decide to self-harm or inflict harm on other people or other things because that's how they deal with it, right? And so it's all the same thing at the end of the day, but how it's being translated in our brain and how it's being expressed, that we begin to understand the connection.
people with the ID have several symptoms, and we talked about the amnesia aspect of it already.
Mhm.
And the article that I got from this medical booklet, I think it was that they um, some of the symptoms may indicate that another disorder is present, but some may reflect the intrusive of past experience in the present. For example, sadness may be indicate of coexisting. Okay, so basically they're saying that they could have depression, or it could be a side effect of the DID. Same goes with
Mhm.
schizophrenia. Like
I think that
a lot
for
of
all
people,
Well, and
disease,
that's
a
though.
lot
true
of
with all
people
mental
are
illness. There could be
diagnosed. Yeah,
comorbidity or not.
right. So like it could have been a misdiagnosis of schizophrenia versus DID. Many people with dissociative identity disorder are depressed and anxious. They are prone to injuring themselves, have substance use disorders, episodes of self mutilation, and suicidal behavior through thoughts and attempts are common, as is sexual dysfunction. The actions
So are
that
we
patient
talking like
zero did, I can see how that fits in with the DID.
Mhm.
so hold on, because I do have only one of those like sticks out that I have a question about,
Yeah,
because all
ask.
of them kind of make sense. But the sexual dysfunction, is that meaning kind of like with patient zero, how like, you were with her, Krista, but she had like an alternate that was like really into guys? Is that what they're meaning? Like,
I
I
think
or is
honestly
it
don't know
something
because
different?
that was not a symptom that she had.
I think what they're
Um,
talking about is like from the if the person was sexually abused and that's what led them into DID, then they're going to be
Mm-hmm.
dysfunctional in their sex life, whether they abstain or they seek out dangerous situations.
but hypersexual,
Yeah.
yeah.
So, yeah, it's basically any abnormality in their sexual response cycle that a person has, is basically what it alludes to. So it could be something like, they become asexual when they transition. They don't see themselves as compatible with whatever species, race, gender that they're supposed to be attracted to. There's various ways to describe it, but essentially it's anything like they say now people with mental disorders are non-psychonormative, right? It's a very soft way of saying that they don't fit into normal description of a normal person, as much as we now have could really define what normal is. And so the same thing is applied to sexual behavior. Some, maybe they are attracted to objects or animals or, the same sex, opposite sex, anything that's not normal for their core personality is what that function would be. But if it's core to the altered personality, it's not considered dysfunctional. So if they transition, let's say, from a same sex woman, um, and they go to a straight male, right? Then they're not dysfunctional because that persona is straight and male, so there's no dysfunction. But if it was, a male who desired to sleep with a horse for whatever reason, that would be something out of the norm. So that's when that kind of fall in. It also classifies for normal stuff too, like just straight dysfunction. So if they transition and they suddenly just had no desire for sex, or they couldn't become aroused even if they had a desire, like elder men with ED, something like that, that also falls under that.
Krista, do you have the psychological interview questions for DID?
The psychological interview questions
Yeah,
for
like
DID?
yeah,
For like
for the
determining if you have it.
right.
You mean the diagnostic criteria?
Yes, that.
Hold on, let me pull it up. Disruption of identity characterized by two or more distinct personality states, which may be described in some cultures as an experience of possession. The disruption in identity involves marked discontinuity and sense of self and sense of agency, accompanied by related alterations in affect, behavior, consciousness, memory, perception, cognition, and or sensory motor functioning. These signs and symptoms may be observed by others or reported by the individual. B.
Oh.
Recurrent gaps in the recall of everyday events, important personal information, and or traumatic events that are inconsistent with ordinary forgetting. C. The symptoms cause clinically significant distress or impairment in social, occupational, and or other important areas of functioning. D. The disturbance is not a normal part of a broadly accepted cultural or religious practice. Note, in children, the symptoms are not better explained by imaginary playmates or other fantasy play. And E, the symptoms are not attributable to the psychological or the physiological effects of a substance. For example, blackouts or chaotic behavior during alcohol intoxication, or another medical condition. For example, complex partial seizures. So, and then you have to meet a specific combination and number of criterion to be diagnosed.
Can we dumb it down just a little?
Sure. What do you need explained?
Oh, no, it's just I understand the big words, but I know some people like who listen to this might not understand the big words.
So, I mean, it's basically like how Laura was explaining it at the beginning.
Mhm.
It's a fracturing of the person's personality into more than one personality within one person. And it's marked like you can see it by body language, behavior, um, habits. They forget things. There are, like sensory motor, like I said, body language, I guess would be sensory motor. Having those lapses in memory that isn't just like, oh, I forgot what I had for dinner yesterday versus I forget what I did for like half of the day yesterday. Um, having knowing that this disturbance or this change isn't something that's like considered normal culturally or within religion, like they said, like kids that have imaginary friends. A kid with an imaginary friend is not the same thing as a kid with DID. Um, and it's not that, they were intoxicated or they have some kind of medical disorder that causes delusions or delirium or anything like that. So I think that
Okay.
hit on everything.
Yeah, you did. I was just, because I mean, I'm going into like, I think I said it at the beginning when we started this podcast. I'm going into the radiology field, so I understand a lot of like the big words, but I know that there's some people who aren't in medical
This is a
and,
podcast for the everyday people, not for the people who
Yeah,
Yeah,
no,
this
that's
is
fine.
yeah.
That's
medical
So
fine.
words.
that's one of the reasons why I was saying being like, maybe because you said it. I mean, you said it point blank. How it's written and how most like medical professionals would discuss it. It's just for the everyday, Susie or Joey sitting at home listening to it. They're probably like, "What the heck did she just say?"
Looking to see if they say anything in here about recommended treatment.
Of course,
I mean,
Talk
obviously
therapy.
talk therapy, and I can't say it enough. We need to normalize therapy. Everyone should be in therapy. I don't care if you have an official diagnosis or not. There is nothing that can replace just having someone who is an unbiased third party who's not going to judge you, that you can just unload all of your crap onto. It's, and there are different kinds of therapy for different people. You have to kind of find the one that works for you. But I'm a big believer in there is a form of therapy out there for everyone. And that it's really, really important to address that and to look into it and just to have that, we all have that person that we vent to. Sometimes it has to be a professional person because, for whatever reason, you don't have a family member that you can complain about your family member to. Sorry, I'm
Or
off my soapbox now.
problems just might be a little bit more than what your friend or family member can handle or help with.
And I'm sure that there are medications that can address the symptoms within DID. Like if you have a comorbidity with depression, there are antidepressants.
yep.
If you have a comorbidity with a seizure disorder, there are seizure medications.
Mhm.
But that again, it all goes back to getting with a therapist that you can connect with, who can connect you with a psychiatrist that can talk medication with you, and just starting from that first point.
This is interesting because this says sometimes uh, guided imagery and hypnosis can be
Mhm.
treatments.
That doesn't
I've
surprise me.
heard hypnosis working for like people who have like really bad PTSD, of like going through it and working through the trauma.
Mm-hmm.
Um, I'm not one for hypnosis, mainly because I don't listen and I don't relax. So
You don't listen?
I
Do
know,
you
What?
shocking.
Tesh, do you meditate? Have you ever done like a
No,
guided
I
meditation?
have
And
Have
I've
you ever
heard
no,
about
I
it.
tried?
struggle to do it. I
You
struggle
struggle?
really
Okay.
hard.
All right, so
But
let's
it really
go ahead.
I was just gonna say, it doesn't surprise me that the guided imagery and stuff like that. I think that EMDR would probably also be very
What is
effective in
EMDR?
treating DIDR. Eye movement desensitization, and I forget what the R stands for. But it's Laura, if you remember Mariana on the Fosters did EMDR. It was when she did the therapy with the light bar and she followed the light with her eyes and focused on that while they worked through her trauma of being left by their mom.
Okay.
So I actually, once I get my license, I want to get certified in EMDR. I think it's fascinating because it helps you address the trauma, deal with the trauma, and then rewire your brain so that you don't have those trauma triggers the same way that you did. Um, Again, like I've said a million times, the brain is fascinating. So, and I've heard a lot of very positive things. I have a friend who's actually starting EMDR, and I told her I can't wait to talk to her and like pick her brain about all of it and how effective she's found it. So
CPR
I
stands
think
for
that would
reprocessing, but I'm not sure.
I don't remember. I could look it up.
One
Okay,
thing to
I'm
say though,
done.
like we definitely want people to explore mental health and to take the steps necessary to protect yourself. But to add a caveat to that, um, people also need to understand that mental health isn't just therapy and it isn't just psychiatry. It's about having a positive support system and knowing when you need help. Like recognizing the problem is step one, because in order to find the person who's going to work for you, you have to be receptive and open to that. And you know, like I myself decided to go into therapy when I reached a point where I felt I couldn't control it anymore. And it wasn't like I was dealing with it for years. It's just at one point in my life, everything just seemed to barrel onto me, and I felt like the normal things I do to deal with normal day stress or even a greater amount of stress simply weren't working. So I decided to reach out, and I think that's important for people seeking mental health, that it's okay if you're handling it productively. Like, right, if your life isn't going the way it should, there's a lot of things, and especially if the people around you who care about you are telling you that there's an issue, you need to be receptive to that feedback. But just like a normal doctor, you don't want to create problems that aren't there. You don't want to become a hypochondriac and assume you have everything because you read WebMD and get yourself tripped up with a bunch of stuff. So it's important to, you know, look at it and use that support structure that's best for you. A lot of people have stigmas about doctors, right? And it feels like people are just pushing them towards something. So if you're not going to be receptive to it, it's not going to help you.
Okay, we need to shift gears and start talking about BPD, which is borderline personality disorder.
Mhm.
Borderline personality disorder is a mental health condition that is characterized by a pervasive pattern of instability in relationships, self image, moods, and behavior, and hypersensitivity to the possible rejection and abandonment.
Yes. So for us laymen's in the audience, basically
Okay,
people's
I
personality
can
traits are flexible or
I can
inflexible.
explain it perfectly. So people always wonder why the smallest thing I can have like a mental breakdown. We people with BPD feel their emotions at where like normal people feel them at like let's say a 9. We're at 100. It is described as one of the most painful mental illnesses there is. Imagine having your body burnt third degree 99% of it, and every little thing has a chance of making you become in pain. So it's not just it's one of those things where like why a person with BPD, someone could drop a fork and say something stupid, and all of a sudden because their tone changed, oh, they're mad at me, they hate me, they don't want to be friends with me anymore, I need to leave them before they leave me.
It's also one of the reasons that you grow super attached to characters in movies and books and people.
Yep, that's why I refuse to finish certain shows or I stop at very specific parts.
Or when you find your group of people, you're afraid anything's going to happen within that group, that you're going to lose somebody because of that fear of rejection and abandonment.
Mhm.
I'm gonna say I identify very strongly with this conversation.
And it's not just that, it's we pick up on body language, tone, a change in any type of our routine. So, like, for instance, Bubba. If Bubba doesn't message me first thing in the morning when he wakes up, and I know his schedule, all of a sudden, oh my God, he doesn't want to talk to me. Oh my God, he's leaving. He can't deal with this anymore. And
What did
Bubba's
I
my
do
person.
wrong? Why is he mad at
Yeah,
me?
why is he mad at me? Why isn't he talking to me? I knew this blew up, and he said not to worry about it, but I'm going to worry about it because now this is happening and I know this person's mad at him because he's spending more time with me instead of doing this stuff, and it just goes on and spirals down and down and down. And so he understands that, so he'll let me know, "Hey, I have to go help my dad. I'm up. I just won't be able to respond as fast. And to him, it's not a burden to just do that little bit of reassurance for me where it's, I'm not mad at you, I'm just busy. Because if I don't get that, then it's, what did I do wrong? They're going to leave, so I might as well leave. And then you find one little thing to pick up on and to start an argument, or to just stop talking to them, or to sit there and all of a sudden it's, oh, well, so and so said this as a joke. And let's say it's about the way I look. Then it's, oh, well, I have to cut my hair now. They said my hair looks ugly. And it's because we have such bad self-image of ourselves too, where it's because there's 9 different symptoms, and I've been diagnosed as bipolar 1, bipolar 2. I have major depressive disorder, anxiety disorder. I have social anxiety. I have CPTSD. Is that what it's called? Childhood post.
CPTSD.
Yes.
Is that childhood or complex?
I think it's childhood, because
I'm not sure.
I can't remember off the top of my head. My list just keeps growing. So, but part of the reason why is because I've been in therapy for so long. I know how to skirt around the truth when they ask the questions to not be diagnosed with something. Because, like, I was diagnosed with borderline or bipolar disorder 1 first.
But how does that
This
help you
oh,
by lying?
I'm getting there.
Okay.
So I got diagnosed with borderline or bipolar 1. And is that the one where you don't go manic, you just get really depressed, and then I can't remember. But so that doctor spent 10 minutes with me and said, that's what you have. Have a nice day. So I'm like, okay, he's the medical professional. Whatever. And the reason why he diagnosed me was because my mother had it, and bipolar disorder genetics play a factor in. So I was like, okay. And then I got re-diagnosed after an incident happened, and I was diagnosed bipolar 2. Well, then through my divorce, my ex-husband threw out, oh, well, she's crazy. And I was like, well, I'm like, I've been on combinations of medication. Like, no one would listen to me. I was either drooling and a zombie, or couldn't sleep, or just something felt off. I couldn't explain it. Just something was off. So finally I'm like, you know what? I'm not going to lie. I'm not going to hide things, whatever. So the 9 symptoms are fear of abandonment. You have unstable relationships, unclear or shifting self-image, impulsive self-destructive behaviors, self-harm, extreme emotional mood swings, chronic feelings of emptiness, explosive anger, and feeling suspicious or out of touch with reality.
And I've seen a
Uh,
couple of those in you.
oh yeah, most people have.
Well, and I'm
But
pretty sure patient 0 had undiagnosed bipolar or borderline personality disorder.
yeah, and
Yeah.
Cruel Intent, or is it Girl Interrupted?
Yes.
Winona Ryder had borderline personality disorder, that show or movie or whatever it is. Like, my biggest thing, the thing I always lied about, was the self-harm, the self-destructive behaviors, the feeling suspicious or out of touch with reality, and the chronic feelings of emptiness.
And when you say emptiness, you're meaning that you just don't feel anything?
Yeah. You may mask it and act like everything's fine, but literally you feel nothing. And so it took me a while to come to terms with this, because you can't just pop a pill and do talk therapy and life gets a little bit better. They have DBT training, which is dialect.
Dialectical.
Yeah. And so this type of therapy is a year-long program, at least in my state. This book is, how many pages is it? 400 pages, and it is worksheet after worksheet after worksheet. Mindfulness, I am so sick of that goddamn word.
Oh, I'm so bad at mindfulness.
But like they have and to some people it's going to look like, oh well, that's just common sense. Like one of the tools they taught us was to plan ahead. I was when I kind of spaced out that this week's topic was BPD, and so I had to plan ahead, and it sounds stupid, but I have a little stuffed animal that I have sitting on my lap. So if I get upset, it's you do a mindfulness where, okay, you're holding this thing, what do you feel? What you're looking at it, you just kind of do that.
Krista, you've done those mindfulness tricks with, I believe it was Anthony when he got really anxious, didn't you?
Yes. Yeah, so there's a bunch of different ones. The one that I do with Anthony, because it seems to work really well with him and is a favorite of his, and it does fall within DBT, which really DBT is really just kind of retraining your brain how to respond to triggering events. And with Anthony, what I do is the 5, 4, 3, 2, 1. So it's, you have 5 things you can hear, 4 things you can see, 3 things you can smell, 2 things you can touch, and 1 thing you can taste, or whatever combination. And it takes the focus from you feeling anxious, because when you're feeling anxious, then it builds on the anxiety and then you just spiral out of control. And you're taking it off of the feelings of anxiety and focusing on the world outside of you. And it helps you to calm down and kind of take that space that you need. We did that at a football game once during marching band, because there were just too many people and he got too overwhelmed. And it brought him right down. And he's very much physical touch, and so am I. So I stood with my hands on his shoulders, forehead to forehead, and we went through his 5, 4, 3, 2, 1. And by the time we got to like 3, he was already calming down. So those, for some people, those really, really work. But I can understand the being sick of the word mindfulness. That's like when we were in
It
COVID and
oh,
these unprecedented times. If I ever hear that phrase again, I'm gonna,
like
yeah.
I get it. Like I have so when I entered into DBT, I have these flashcards that are on like a little key ring that are all laminated. And if I'm having an extremely rough week, yeah, I'll throw them in my purse just in case. But it's just I don't do well in group therapy. But I do work on it on my own. I kept the workbook. I didn't toss everything. It's just for me, I don't do well in group therapy. It's probably the trauma response of being locked up in the loony bin as a teenager. But
I do have to say that I'm proud of you for throwing that key ring of those flashcards in your purse when you know that
Mhm.
you're having a rough time.
Mm-hmm.
yeah, and like I have sensory things. I have sensory things in my purse. If it happens, like my boss has walked in once or twice where I'm sitting there rubbing a stuffed animal. And he's like, okay, go outside, go take a walk. He's like, I saw Oliver. So we have these bunnies that live in our yard at work, and I named them all, and he'll come in, and if he's knowing I'm having a bad day. But since Chesh got a little confused with the BPD splitting.
Mhm.
So what splitting is it's black or white. It's if, like, let's say Danny's tone changed with me.
Mhm.
All of a sudden he's totally evil. He doesn't like me. We don't like him anymore. We're done.
Okay.
It's good or evil. It's white or black. It's you like them or you don't. We just split, and it's
So,
that's it.
is it kinda like how I get when, like, if you and I don't message for a while, I immediately think you're mad at me?
Mhm. For us, it could just be a tone or
Mhm.
a change in our routine. Like, I've gotten so used to specific things in routines where all of a sudden it changes. Oh, they hate me. Well, we hate them too. We're not going to talk to them. We don't like them anymore. They're assholes. And then they do one other little thing like, "Oh, I'm sorry, I forgot." It's like, "No, you didn't fucking forget. You just don't care no more."
Mhm.
So we don't. No, we're good. You go do you. I'm gonna do me. And it's part of the self-destructive relationships
Boy, I'm glad you never reacted
that
that way with me. Because I know
Who, me or her?
Jess. Because there's times
it's.
that we go weeks without talking, and it's not for any reason.
Oh yeah,
But if
no,
that's the
I'm
norm in your
glad.
but
relationship, then
Yeah.
that's
that's
not a
normal
problem.
in our
Yeah.
Yeah, so
relationship.
I'm
If
Where
glad
you're
that.
used to talking to
yeah,
someone every single day and they always text you at 9 a.m. and then one day something comes up and they don't text until 9:01, that's it. They're dead to Jess.
Yeah. Yeah,
we'll
so
see.
I'm glad
So
You
that, because
it depends on the person.
for a
Like
while
if
there,
it's
we were texting every morning, the three of us.
oh yeah, and then it
Mhm.
just slowly life happened and
Hmm.
other things, and it's one of those things where I'm getting a lot better with it, but I think the only person and that it still would be really bad with would be MJ.
Mm.
And like all of a sudden he sat there and I didn't notice it because I was busy at work one day. And all of a sudden I look down and it's because he's been doing it a lot earlier. He's trying to get his schedule to a normal human being sleep schedule.
Mhm. Which I'm very
And
proud of him
that.
for doing so, because that's not easy.
oh, he usually stays up till 5, 6 o'clock in the morning and then wakes up 2, 3 o'clock in the afternoon. But now he's getting
Mhm.
up between 9 and 11. So I have a larger window, but all of a sudden I didn't message him back right away because I was married. I was I was
Whoa.
Excuse me, ma'am.
I was busy. And he's like, I was like, "Oh, hey, sorry." He's like, "No, I figured you were busy." He's like, "I just wanted to make sure that I texted you." And when you didn't text back being like, "Oh, you must be busy. Just text me when you're done." So he even to him he was like, "Okay, this isn't normal."
Right, because you have a routine.
Yeah, and we like I sat there the weekend of my birthday.
Which I missed,
Um
by the way. Happy belated birthday. I'm so sorry.
oh, oh no, you're good. Um we had the art festival that we have down in Minneapolis every year. And I was like to Sean, I was like, "Okay, well, we weren't supposed to have his kids even though it was his weekend because things got switched up and everything." And I looked at him, I was like, "Okay, I am preparing to go downtown with 2 children. 2."
Mm.
I was like, "We can't be switching this to 5 children. I can't do it." I was like, I have prepared ahead. Prepared ahead is a lifesaver for me, especially when it comes to leaving my house.
Hmm.
Like that was the one she was like, "Nope." My therapist was like, "We got to get you into that because you use every excuse out of the book being like, "Oh, well, you know what if there's too many people there? Never mind. I'm not going to go now." So she's like, "You're preparing to be around a large crowd." But see, then the downside is if I'm preparing for a large crowd and there's not a large crowd, then I'm all out of whack.
I can see how that's an issue.
But a lot of it also is like sensory. So there's another DBT where if your anxiety gets really high, or for me it was one where the self-harm came in, and it's like, okay, when you get to that point, go upstairs, open the freezer, stick, and it sounds funny, you stick your head in the freezer.
I was just gonna say, are you sticking your head in the freezer?
Otherwise you grab like a bag of peas and you put them over your eyes, and all of a sudden your brain isn't thinking about it. It's I don't remember the term she used, but it's making your brain realize, "Oh crap, you're getting really cold. We need to focus on that and stop that." And it redirects your brain from the how do I want to explain it? From the trauma, like the issue that you're having that's causing you to have like your fight or flight response.
It's a disruption. It
Mhm.
disrupts that reaction.
So May is actually BPD Awareness Month. And so, like, my TikTok got fucking flooded.
Mine too.
Well, it was probably because I was reposting stuff.
Probably, but
to
like
a
even
point,
stuff that you hadn't reposted, I was getting stuff about it.
well, it's because I will give TikTok that where, like, if there's a lot of content being created on, like, mental health, it will start showing up on just everybody's TikTok. But there's a girl I follow and she has BPD. She has gone through DBT. I think she's a therapist too now. I can't remember, but she posts a lot of good videos. And I guess a lot of people now lately have been idolizing people with BPD, being like, oh, I would love to be someone's favorite person. No, you don't.
No, I think I'd feel smothered.
Well, it's
You
not
would,
even
Laura. You wouldn't
you
be able
would,
to.
trust me. So, like, my favorite person. Everybody assumes it's Bubba. It's not. So my thing is I've gotten better where Bubba isn't my favorite person. He's just my go-to person. And like I did explain it. I can lose Chush or Laura. It's the fact that I've never had a fight with him. He tells me what I need to hear, not what I want to hear all the time. Like every time. He will support me, but he'll be like, "You know what? I think this is a bad idea, but I'm going to support you. I will be there to pay." Like, but that's not my favorite person. It's a person where their tone changes. I change my personality to fit what they want. I idolize them. I want them to like me, so I'm going to do whatever I need to do in order to make them like me and to be happy with me. And the moment they either stop talking to you or anything changes, your whole world crashes down. You literally would rather die than lose that person. And it is not something someone should want to be for someone else because you're not guaranteed to always be there for that person.
Right, right.
True.
And that's the hard part is I'm trying to get away from having a favorite person. That's why I'm trying to branch out socially more. I'm trying to not get so attached so easily because it is devastating when someone leaves. Like, look at He Who Shall Not Be Named.
Mm-hmm.
I still have effects of that because he was my person.
Right.
And to just be dropped like I wasn't important. And the fact that when I finally was diagnosed and he's like, "Oh, well, I could have told you." Like, that was a slap in the face.
Yeah.
Like,
What about Sean? Does he fit in there as a favorite person at some point?
he did, yeah. Not so much anymore. But he is trying to learn a little bit more.
So I don't know if it's common knowledge or not, but the podcast was born out of a therapy homework assignment for Jess.
Mm-hmm.
And how do you feel?
Hated the fucking.
How do you feel that it's going for you?
It's going good. Like, I enjoy it because to me, I've always had that thing of my mom was bipolar, my mom was an alcoholic, my biological dad was an alcoholic. My One of my other sisters has to have some type of
Something.
issue. My little sister has depression, like, and it was always swept under the rug.
Right.
Like, I was diagnosed with depression as a teenager. I tried committing suicide a couple times, been hospitalized, and it was always hush hush. And I was just like, this doesn't help, right? Acting like it's not real, acting like it's not there. It doesn't help. And the reason why I jump from therapist to therapist is because I still have in my mind of, like, I had a really great therapist as a teenager, but because he called out my mom on things, she made me quit going because he wasn't saying what she wanted him to say, that it was all my fault and everything like that. So after that, I was like, "Oh, so I just say what they want me to say. They think I'm getting better, and then I can go on my merry way and I'll be fixed." when there is no, you have tools, you have to work at it every day. It's not one day I'm going to wake up and everything's going to be normal. I'm not going to have to use skills or anything like that. It's just, it's one of those things where the reason why I don't care about talking about my BPD, or if we do major depressive disorder or bipolar disorder or any of that, is because the less we talk about it, the more stigma there's going to be, the more people aren't going to want to get help, the more, like, we're in Men's Mental Health Awareness Month, and men die by suicide all the time, but everybody acts like, oh, we should just sweep it under the rug because it's not important, because it's such a bad topic to talk about. No, the more you talk about something, the more you can get more funding for programs,
Right, which is
or
why we're doing all of this.
As far as talking about mental health and men's mental health and suicide rates and all of that, none of that's going to make all of this happen more, but it's going to get rid of that stigma and normalize it and let people understand and realize they're not alone in what they're struggling with, and that it's okay to not be okay, and it's okay to need a little extra help here and there.
And it's okay to ask for that help.
well, I think the scary thing for me is the average life expectancy of a person with BPD is 20 years lower than the average American. Because a lot of times when people are at that point where the self-harm could like, a- and with self-harm, it's one of those things, we're not crying for attention because most of the time we're hiding it. We're not doing it like some teenagers do, and then they cover it up with bracelets and stuff like that. We're very precise and sneaky about it. Like, Sean didn't even know about it until I finally was just like, yeah, this is what happens. And he was just kind of dumbfounded, like, how didn't I notice this? Where it's, you could accidentally cut too deep or burn too deep and get an infection. And it's because when we decide to try and check ourselves into a mental health facility, to them, till some, not all, we're just looking for attention. Because even in the mental health field, especially, like my therapist told me, was BPD is so hard to understand, because like antidepressants will help with the depression side of it, and anxiety medications will help with the anxiety, but there's no medication to make you not feel your feelings from 1 to 1,000.
Yeah, and it says that there's only 3 to 6% of Americans have BPD.
Mhm.
So it's, I
I
can
think
understand
it
why it's
gets
not understood.
I think it's hard to diagnose and it gets underdiagnosed.
Mhm.
Or it gets misdiagnosed as major depressive disorder with anxiety, or you know what I mean? Like,
Bipolar disorder, and
mhm.
and a lot of the times, I think, because I asked my therapist this, I was like, I was 100% honest for once, and she's like, yeah. I was like, is that kind of why, like, I got diagnosed? She's like, yeah, because most people aren't going to admit, yeah, I cut myself, I burned myself, I starved myself to make the pain go away. Because, like, for me, it was, how I explain it to people is, for that one split second, or however long I'm doing it, I don't feel anything. It doesn't hurt. I feel numb. I'm not feeling 50 million different emotions all at once, being overstimulated, not knowing what to do. And self-harm isn't just that, it's binge eating, where you're eating so much you hurt, or eating disorders, and stuff like that. It's, or bashing your head against a wall, or pulling your hair out just to feel something that you're in control of, because you're controlling how long you do it, how many you do, how deep you do it. You're controlling it. So for once, you feel like you're in control of your emotions because you're causing it to yourself.
I think a lot of this has to do too with the culture being fed too many PC terms. Like in trying to make awareness is great, but a lot of people don't want to shine the light on the full subject. They want a safe, digestible chunk So we come up with a lot of broad, very non-offensive or very clinical sounding terms to explain a very nuanced thing. And so even in the medical books, and the vernacular they use is very broad stroked. Like a disorder with that level of complexity, like DID or borderline personality disorder, you can't simply say, oh, well, they have symptoms. Well, duh. Everything has symptoms. You need to be more precise. We need to know what makes it so different, why one medication is not going to solve it, right? And I think that's what we need to make more normal. I think we need people to stop being so afraid of these things, and instead of just using these soft, non-offensive terms, we need to have things that call out what's really bad about it. When someone's
Yeah.
missing a leg, you can't call them a non-physical normative person. They are missing a leg.
They're an amputee. Like,
Right. They're,
is that
like,
a not a PC term, or is that
well,
offensive?
a lot of those are becoming that way. And that's the problem. We've catered so much to people without real conditions or minor conditions by example, that microaggressions and things have become the order of the day. And this is the same problem that helped mental health to be stunted in the first place, is people didn't want to face it. They wanted to shove it under the rug and have it be someone else's problem. Places like Sunnyvale back in the 70s and 80s were the result of people just not wanting to deal with the reality of a situation, thinking they themselves share something in common with someone that they look less on. And that's the issue, is people, normalizing it is fine, but it's also making sure that people understand that just because it's something that we can talk about, you have to be ready for the reality of what we're talking about. Like
Well,
medicine is a good example. Like,
mhm.
if you've never seen an operation and seen the insides of somebody and seen what the human body really looks like and how it reacts to lack of blood or, you know, um, aggravated wounds and things like that, you can't really conceptualize the idea of what's going through. So when surgery, people go, I'm scared, I'm scared, I'm scared. Well, of course they're terrified, because all they ever say is, it's okay, and we're going to put you under, and you're not going to feel a thing, and they give you a bunch of percentages. That, cancer is the same way. We all know cancer is terrible. When you hear it, it just shocks people at the core, but they don't tell you that many people deal with cancer and are dealing with cancer, have gone into remission several times. They don't tell you any of that because they're so afraid of, the 20% who aren't going to make it or going to die within 2 weeks, and they don't want to get sued and all this kind of stuff. So they don't go into that. And I think mental health needs to be that. You need a hard, fast, knock people over the head approach, and not to be pandering to people's desire not to face reality.
Well, like when I was diagnosed, I wasn't told that my life expectancy was 20 years less than the average human, because heaven forbid I might just off myself.
Right, and that's what they fear. And in some people that's a good thing, and I understand it. But like my son went through bouts of really bad depression. He still deals with it, and he had suicidal tendencies. He went into a hospital and got checked in for a while. But they all gave him that same kind of like, it's okay and blah blah blah. And I thought everything was going good. I trusted the doctors, I trusted his counselors, I trusted his therapist, and he still tried to take his life. And I said,
Well, and
okay,
that's
this isn't working. So I had to take a very strong approach to him. And I did something that was very controversial. And I won't bother sharing it here, but it worked for him because it wasn't everyone telling him these stories and fantasies about what could or shouldn't or may or not, and gave him definitive evidence of this is what's happening, facing his mortality directly. Now, it didn't cure him, but it allowed him to understand and give it a name. It's, instead of it being the boogeyman, it had defined parameters. It had something more tangible he could latch onto.
Yeah, and like for me, I was trying to explain it to one of my sisters, and it really annoyed me when she's like, "Oh, well, maybe you just need to go get your chakras realigned." And I believe in that kind of stuff. Don't get me wrong, but I kind of looked at her and was like, "Are you dumb?"
Well, have
I'm
you
like,
tried just being happy or smiling more?
Oh my god, I'm gonna
Right?
punch you. But no, and I kind of looked at her. I was like, no, I didn't think of that. And I'm just like, why is it so bad? I was like, you're the one that told me, oh, well, something's off. You need to go get diagnosed. So I do it. And then I'm trying to explain to you guys what's like all of my siblings are like, besides my little brother who's on the spectrum, to them, it's still a naughty subject to talk about mental health. Like, we don't talk about how
Mhm.
mom was unmedicated on her with her bipolar disorder. We don't talk about how she was an alcoholic because that looks bad on the whole family.
Yeah.
When
We don't talk about Bruno.
I was trying
yeah,
so hard not to make that joke.
well, and the tough thing is for borderline is it's a makeup of environmental factors, trauma, and brain chemistry. Like, they've done brain scans and certain parts of the brain are more, they light up more when certain things are happening. We don't have a good what part of the brain does like emotions where it's like smaller or larger?
Ugh,
I can't
I
I
should
can't
know the answer
remember.
to that.
I don't know the brain.
But
Sorry.
yeah, I don't either. All I know is I
I
have
was just
one.
like, I should know. Are you sure?
But but it's just a lot of times it's one of those things where the reason why we have a favorite person or we get so attached is like I didn't growing up I didn't get much affection. My dad was not big on I love yous, neither was my mom or anything like that. So for me, when I start to get affection from someone, I cling to it. And it is not like necessarily a romantic affection. It's just getting someone's attention because I was deprived from that. Like, I was the middle child, 8 years older or more, 8 years younger or more. I was responsible taking care of my little brother and sister, so I didn't get to go play with my friends. I got deprived of those kind of relationships. So I try and fit in where I can, and you tend to lose yourself with
Mhm.
that. And there's actually 4 different types of borderline personality disorder.
Oh, really?
Yeah, so there's discouraged, which includes avoidant, depressive, or dependent behaviors, operating in abandoned child mode, and frantic efforts to avoid the end of or disturbance of any relationship, black and white thinking, or unstable sense of, and it got cut off.
What is child mode?
So, an example would be, I'm trying to think. So, like, he who shall not be named when he left.
Uh-huh.
Mhm.
When he did it the first time, I threw a tantrum. And I was like, no, you need to come back. We all miss you. All this kind of stuff. When he was like, peace out, guys, I'm gone, blah, blah, blah. He wasn't talking to anyone.
Uh-huh.
Mhm.
And you're throwing a tantrum to get their attention to come back.
Okay.
Whereas the second time, I didn't do that. It was like, okay, peace, bye. I'm blocking you
out,
on
Girl Scout.
everything. Yeah. Then there is impulsive, which includes antisocial or approval seeking behavior, poor impulse control, constant conflict with society, and seeks approval at any cost.
Huh.
There's self destructive, which includes depressive or self destructive behaviors. So, not just self harm, but spending sprees, drunk driving, driving excessively fast, substance abuse, stuff like that. Then there's popular cultural image of person, gath or emo. I don't know why it's gath and not goth. Um,
Yeah, I was like, what the fuck is a
it's
gath?
Probably a
GATH.
typo. It's
Yeah,
probably a typo.
often suffers from depression as a co-occurring diagnosis and is a self-injurer. Then there's petulant.
Petulant.
Petulant?
Petulant, thank you. Passive aggressive behaviors, operates in an angry child mode, unstable sense of self, a frantic fear of abandonment, inability to express his or her needs. And then world is a problem, not him or not her, not them.
Not it.
And so usually you have a core borderline, and then you can have like little bits and pieces. So like I'm a discouraged borderline, but I have little bits and pieces from all the other ones that go
So
with
it's
it.
not like copy and paste of how you read off
No,
each one. It's like, okay, I have mainly this, but sprinkle in
yeah, so for
some of the
me,
others.
I do avoid. I am dependent. I do operate in abandonment child mode a lot, and I do try to avoid like ending any friendships or relationships because of that abandonment. But I have poor impulse control, which then goes into the self-destructive behavior of I'll overspend.
It's only been very recently that we do regular risk assessments with people. And I know my youngest, Christian, had a really unexpected breakup last winter. Um,
Mhm.
and was in a deep depression. Like I had never seen him like this. He's usually, even when he's having a rough time, he gets up, he interacts, but he was like on the couch for days on end. And I straight up just asked him, "Do you feel like you're going to kill yourself?" And I know people balk at that kind of phrasing, but why are we sugarcoating it? Why don't we just straight up ask?
Mhm.
It's not going to put a thought in his head he didn't already have
Right.
if he already had it.
That's going to be it for today's podcast. We appreciate you all being here. Please get involved with the conversation in the comments below.
Follow, like, subscribe, comment, do a
Share.
happy dance, join the Discord.
Bye.
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 Yeah.
I love that you own your diagnoses and know your disorders.
I say I want to be normal all the time, and part of it is just because of the fact of the negative stigma, but it's also it is exhausting.